At this time, we'd like to invite our panelists to the front of the room. Get it going. We have Benjamin Oldfield, Jennifer Edelman, Michael Fingerhood, Judith Feinberg, and Honora Englander, I guess, is Skyping in, joining us online. Though not all of our panelists have been able to join us for the entirety of the workshop, we would like to hear their opinions on what they have heard today, as well as opinions on the major barriers and facilitators to providing integrated services for opioid use disorder and infectious disease. Unfortunately, Carlos had to depart a little early, so you're stuck with me. So rather than make full introductions, the bios are available in the packets. We'll just ask our panelists to provide their titles and affiliations and a few sentences about your work and research as it relates to the topic of this workshop. And to that end, I would just point out that the statement of task includes the committee will identify and highlight programs that are achieving integration as well as barriers to integration, and may suggest strategies to address these barriers. And conclusions and recommendations will follow. So that's really what we want from you all, is how do we address these, identify and address these barriers to integration. So carry on. Start on stage left.
Sure. So this has been such an inspiring day, and I'm really happy to be here. My name is Ben Oldfield. I'm an internist and pediatrician. I do primary care medicine and addiction medicine, largely at a federally qualified health center in New Haven, Connecticut, and I'm on clinical faculty at the Yale School of Medicine. My research focus have been on quality of integrated care for opioid use disorder and its infectious complications, and particularly thinking about how to measure quality of that integrated care.
Hi, I'm Jen Edelman, general internist. I practice HIV and addiction medicine. I serve as the addiction medicine consultant at our Yale based HIV clinic, and then also spend most of my time doing research focused on that intersection. So issues around implementation of addiction treatment in HIV settings. I'm working on projects related to promoting opioid use disorder treatment with buprenorphine in ED settings as well, and PrEP.
I'm Mike Fingerhood. I'm at Johns Hopkins in Baltimore. I have an appointment in School of Public Health and in medicine. I'm an internist who about 25 years ago created a primary care practice devoted to providing primary care to people with addiction. We are Ryan White funded for all that time. We do Hep C treatment. We have over 650 people on buprenorphine at this point, and look to grow. We also look at novel ways to incorporate buprenorphine. We have a van outside the city jail. On Monday mornings, I'm in a church. We go looking in a variety of places in the neighborhood as well. We also, more recently, have looked at linkages through our consult service by, especially with seeing more individuals with endocarditis. We have created a means that we're going to track of continuing buprenorphine as patients are started in the hospital and continue in skilled nursing facilities, and the use of peer recovery coaches who follow them along the continuum.
Hi, I'm Judith Feinberg. I'm an infectious disease trained and spent the first many decades doing HIV research. And about 2005, almost 15 years ago, I got involved in the infectious disease side of injection drug use and have sort of been moving into that space ever since. So I'm in West Virginia now, where I've been for 4 years, and unlike everybody else at the table, West Virginia is new to this problem, and everything that we're doing there is very much a work in progress. But I think we have some exciting ideas that would be very pertinent to other rural communities.
So I jump in. Thanks so much for the opportunity to be here remotely. My name's Leonora Englander. I'm an internist and addiction medicine physician at OHSU in Portland, Oregon. I developed and direct our inpatient addiction medicine consult service, which we've been implementing since 2015. We're an interprofessional team of physicians, a nurse practitioner, and a PA, as well as social workers and peers with lived experience in recovery. And our work has really been a platform for healthcare transformation efforts across our hospital and hospital systems in Oregon. I now lead an ECHO, which is a telementoring program to spread best practices in hospital-based addictions care across the state. And we piloted a failed model that I presented to some of you about a year ago of integrating long-term IV antibiotics into residential care. So have experienced both integrating addictions care into hospitals and vice versa, medical care into addiction settings. And do a lot of work with our infectious disease colleagues around integration.
Great. So I will, I guess, open it up to the committee to ask questions and just kick it off with, let's start with the biggest and most critical. What are the opportunities here? What can we, as a committee, recommend with some evidence behind it for the nation to do to address the integration of addiction and infectious disease services? Think big.
Okay.
And then we can work. Then we can drill down.
So I'm going to say a couple things. One is I think we have to remove the stigma of medication, that people think that medication is a crutch, and we have to be able to say that. I think part of that is we need to eliminate the term medication-assisted treatment, that it's treatment or it's medication, that the medication is the focus. And the other piece that I think, as I try to convince more settings to integrate, is that there's this fear of starting, and I think the term induction has been a tremendous negative, that we don't induct individuals on any other medication. We start people on medication, and for many people, when they hear the term induction, it means that maybe this is something that I shouldn't do. Relatedly, as we we initiate people or start medication at home, I heard in the last talk that we should focus on the fact that this is like any other medication, that we're starting this for you at home, and most individuals are very aware of the use of buprenorphine as well.
I'll just add to that. I think I completely agree. In the ED-based work, we've been talking about treatment initiation because of this concern about induction and it being a huge process and being very cumbersome, but we know home treatment starts are very effective and safe. And I think also just continuing to reinforce the paradigm of comparing opioid use disorder to diabetes, hypertension, depression, HIV, and the like, and pushing that paradigm kind of across disciplines, just to add to that point.
I would add to the stigma piece that what I encounter a great deal is not only stigma against the treatment of opioid use disorder in the community, but there's stigma against the people who do it, and many of those who are part of stigmatizing others are themselves healthcare personnel. So that actually the education effort is not just the general public, but really people who are already practicing medicine and public health. So these are enormous obstacles. And then it becomes institutionalized. So for example, I got an urgent call a couple of weeks ago from a southern county where I do research, saying from a community worker saying the couple that she helps, who are both doing fine on buprenorphine and want their child back, was told by their Child Protective Services worker that they were not going to get their child until they stopped taking Suboxone. So, this is extremely institutionalized. It's institutionalized in CPS, it's institutionalized in our court and drug court system, as well as within the healthcare profession.
So in terms of actionable items to address the stigma, that would be helpful. I mean, education broadly, but if there's any more specific recommendations that we could give, that would be helpful. And also any evidence that education does actually lead to reduced stigma.
Well, I'm not sure I'm going to be able to speak to the evidence base of education and stigma, Jody, but I would say that we need a very broad-based PR campaign, and I think the success of Madison Avenue tells you that if you pitch a campaign right, you can convince people of just about anything. So I think we need a very slick, very far-reaching campaign across a range of media. Most of West Virginia is not a high-speed broadband place, so it also means traditional media. And I think we need a poster child. I think we need a Magic Johnson. I think we need a poster child so that someone who can stand up and say, really, this is just fine, and I did it, my family did it, whomever, and we're okay. And I think at least in West Virginia and maybe other rural communities, I think we need a blitz at that level.
I'll just jump in with one addition, which is first to agree with the comments that have been made, but also in terms of education, really addressing not just physicians and not just community members, but across medical disciplines, nurses, pharmacists, others. And in terms of one strategy to approach it, certainly in the hospital, in our experience, providing treatment has really changed culture and been transformational. So I think there are things that we can mandate around skilled nursing facilities, around hospital care, requiring access to treatment in these settings that I think is part of how we address the stigma.
We had one other role which I found really useful, which I had mentioned, is the use of community health workers / peer recovery coaches, because they have not only an impact on the patients, but they impact the other staff, because all of a sudden the nurses, the physicians see that there are people who have succeeded. There's an overwhelming feeling among most medical personnel that addiction is futile. And if they can see examples of people who have achieved some element of, this is tough to define, recovery or sobriety, it has a huge impact on healthcare personnel.
And I just wanted to make a plug as a pediatrician. I often think about how stigma might impact children in the institutions that take care of them, and I think particularly young adulthood and adolescence, where a lot of opinions are formed and solidified about which institutions care about you and which might not. And I think that anti-stigma campaigns would do well to focus in the schools and other institutions that address children and care for them.
Great. Ellen?
Thank you. I had a question about housing. I believe it came up yesterday when we were discussing the challenges in treating methamphetamine use and the limited pharmacotherapy options, and someone suggested that housing was actually an intervention that had successfully stabilized some of their patients. And I know specifically Dr. Englander has some experience on this, and I'm sure the rest of the panel does as well, but how we can use and advocate for housing as a means to facilitate integrated treatment for substance use disorder and infectious diseases.
I'm happy. Thank you for the great question. I do have some experience with this, really, in that there's a vast need for housing. Housing instability is a tremendous driver of use and risk factor for return to use. In some of our housing, it's sort of alcohol and drug-free housing does not allow for medication, which I think is also just an enormous problem and something that can be addressed. And actually, Ellen, I'm not totally sure which specific work of mine you're hoping I'll talk about, but in that sort of post-hospital transitional housing, we've had some success connecting people.
Yeah, and not really anything specifically, but just thinking about barriers and opportunities maybe to provide some of these services as part of a housing intervention, HIV testing, PrEP, Hep C, testing and treatment. If you have any thoughts on potential opportunities to use housing to facilitate integration.
Mm-hmm. I think there's tremendous opportunities. There's probably others who know more about this than I do, but again, kind of integrated primary care addiction services and housing can be hugely, hugely impactful.
We're struggling with staying on our task, which is integration of addiction and infectious disease services, because of course, it makes no sense if somebody's homeless to address this, and it makes no sense to not address their mental illness and their whole host of psychosocial issues. So I think that's a challenge to us, but I think that is something that we need to state up front. Dr. Englander, I just wanted to circle back on one thing you said, which I think is very helpful, is the potential for culture change and transformational intervention within hospitals, and that's something that we could mandate, or somebody could say, could have hospitals, maybe a joint a JCO requirement or something. I wonder if we open it up to the panel to say, well, what kind of things could we recommend to make that happen?
I'd be happy to start in terms of what our experience has been and what I think about, in this ECHO that I lead across hospitals across the state. There are hospitals that don't have methadone on formulary. There are people who are told, well, if you want to go to SNF, you can't be on medication for your opioid use disorder. That's illegal, and we see it all the time. So I think that those are real opportunities. There are so many. I think there are many things that could be legislated, and then the implementation of them is more challenging in terms of then you have medication on formulary, but do you have people who know how to use it and use it appropriately and effectively? But again, I think there are regulatory barriers such as hospitals don't necessarily know that they can provide methadone legally in the hospital. They think that it has to be administered at an opioid treatment program. Similarly, at skilled nursing facilities, we run into all of these barriers. I think that another challenge is actually that some states legislate that the opioid treatment programs deliver to skilled nursing facilities. I've been in touch with folks at Hopkins who are doing some of this work, and I know one is on our panel. But in Oregon, we really struggle because we can't get the OTPs to deliver the methadone to SNFs. And so therefore, we have to send people who are really medically ill to go wait in line every day at the opioid treatment program. All of this could be regulated in a way that it would be much more permissible and supportive to treatment. And that matters for a population with infectious diseases. These are folks needing IV antibiotics for months. Where we really run into tremendous challenges, and it's very wasteful also in terms of resources.
By pointing out that it's illegal for SNFs not to accept people on medications for addiction treatment, I think you're referring to the ADA and a recent case out of the Boston U.S. Attorney's Office, which is great. But on the flip side, there's a lot of people that run these skilled nursing facilities that are incredibly hesitant to have people with addiction and mental illness and on medications and managed by people that may not have the expertise to manage these medications, and a lot of vulnerable patients in those facilities that could get injured. So it's a complex that's a complex challenge, and I think ideally we'd find some places that have that would develop expertise. I'm not sure that we're going to be able to get expertise across the board, but what are your thoughts on that?
Yeah, I agree, and I think that there's such a range, and as you described, there's the behaviors, and then there's the medication and the disease. And so I have people who are stable on buprenorphine after cardiac surgery for rheumatic heart disease, who I can't get into a SNF because they've been 20 years stable on buprenorphine. And so that's an illegal scenario. We also have people who have, challenging behaviors, and I think that's a different scenario. I think we need treatment settings that can support folks like that to get care, and some of that is being more creative about how to reduce harms, and maybe we don't require that people stop using, but that they use more safely. Those kinds of things.
Great.
A quick comment. One thing that won us over as we met with, I've given talks at the National Conference for skilled nursing facilities, is the comment that they were having individuals overdose in their skilled nursing facility, and wanted it to be better to have these patients in treatment rather than having people bring them in drugs. So there's a realization that if they're going to accept individuals, which they are, who are there long term, who have addiction and they need long-term antibiotics, wouldn't it be better if they're on medication than at risk for overdose while they're there?
And of course, with the ADA, if they're not on meds, then it's not illegal to discriminate against them because they're not part of a class. It's ironic.
And something I just wanted to also add to the conversation as we're thinking about the hospital setting and the emergency department to be patient-centered is we really need to make sure people feel comfortable managing pain for patients who are coming in with abscesses or post-surgical so that they're not leaving AMA and the like. So I think that's a real big gap right now.
So
Pain and withdrawal.
What's that?
Oh, just to add, it's pain and withdrawal. We see so much untreated withdrawal. It's astounding.
Sure. So what would you do about pain management? That's a gap, but what would you suggest as a recommendation to address that?
So I know some settings are developing multidisciplinary teams in the hospital to review how to bring together pain specialists, addiction medicine specialists, infectious disease, cardiothoracic surgeons, and the like. Sandy, you may know more. To make sure that these issues are optimally addressed for challenging patients.
David?
So, the main, we really would appreciate your help in thinking about practical suggestions to make it possible for, and not only possible, but increase the likelihood of those that aren't doing what you're doing to start doing it nationwide. So, for example, when you think about other in circumstances, whether it's a methadone clinic that's doing methadone really well and doing a great job of that, but it's not doing any bothering with any infectious disease care. If you think about HIV practices or ID practices, they're doing that well, but not doing. How do we? What are some of the ways to make integration happen and sustain it nationwide? And so, Judith, like in West Virginia, throughout in other rural parts, how do you, and I don't know, I'm just wondering, we really could, I want to make sure we get your expertise on this so that our recommendations are thoughtful.
So I think clearly HRSA has communicated to FQHCs and community health centers that they really want them to take on medication-assisted treatment. I agree that's a terrible phrase. We need a better treatment, to take on treatment. And FQHCs have begun to do that. Some of the obstacles to that are what the regulations are in your state. So I really like the idea of low threshold buprenorphine for people, but in West Virginia, because the OxyContin mills became Suboxone mills pretty quickly, the state mandated that appropriate treatment requires all of the psychosocial 12-step, it is a very structured program. And I think while that works fine for some, it's not what everybody needs. And so, sometimes you get this federal-state friction. I think HRSA's emphasis on this is absolutely correct, and we do have FQHCs across the state that are starting to take this on. In addition to the state-federal friction, there's the issue of recruiting appropriate caregivers to a rural state. Very, very hard to do. It's not a place that, despite its incredible beauty, not a place that a lot of people want to move to. And, that's problematic too. We have a real workforce problem. And, I think the cure to workforce problems, or not the only cure, but an important piece of dealing with workforce problems is loan forgiveness, or signing a contract with people as they enter Master of Social Work, schools, or medical schools or nursing schools or whatever. Sign a contract and have them, repay so many years of work after they're trained, and then they may fall in love with the place. So we have those issues too. And then, we already mentioned the stigma, which is very intense and, kind of an uphill issue. But I think in rural communities, there is no better place for addiction care and infectious disease care to happen except at the local level. First of all, nobody's going anywhere. There's no transportation in these areas. There's no public transportation. So then that means you have to have A, a car, B, insurance, C, the car has to run, and D, you need gas money, and sometimes you need toll money. And it's just not going to happen. I would venture to say there aren't 24 ID docs in the whole state of West Virginia. We're not going to take care of the thousands and thousands of people who have hepatitis C and hepatitis B, and now we have a HIV active cluster. I shouldn't say outbreak because doesn't meet the CDC definition yet of an outbreak. And so, it makes sense that the emphasis be local. And I think also would help deal with the stigma, right? You're going to see the same doc you and your family, or the same clinic you and your family have gone to for generations. And as opposed to you're going to the methadone clinic, which is just the methadone clinic, or, I think that helps counter the discomfort that people have. So, I see a number of issues at different levels. I think we're trying to do some very clever things. We just got Health Right, which is a free clinic in Morgantown, just got a waiver from the state's requirement for all of the heavy-duty psychosocial 12-step stuff. And we're going to do directly observed buprenorphine therapy to homeless people with opioid use disorder in Morgantown. They just walk into Health Right every morning and swallow their bupe and walk out. And it's also the area syringe services program, and it's also a primary care, and it also has volunteer people who do ID. It's a free clinic, so it doesn't exactly have docs on staff. But I think that's one way to approach things. The homelessness is a huge issue, and it's a huge issue everywhere, not just, it's in both in urban and in exurban areas, right? So Kentucky and West Virginia have the largest numbers of cases of hepatitis A in the nation, and it's mostly rural. So, it's all got to do with homelessness and inadequate sanitation facilities. So, there's some ideas. There's no magic bullet. We need a hail of magic bullets. We need a lot of different approaches.
I also think, just a quick comment, included in our gaze on treatment should also be a focus on screening, because to my knowledge, the guidance from HRSA for screening for substance use disorders in HIV care settings is basically that these settings screen once a year for substance use disorders, but further guidance on what screening tool to use, who should be doing that screening, in what context should it happen, is lacking, and that leaves clinic settings like FQHCs, where I work, with a lot of a dark area in terms of how to actually implement these relatively simple and lower hanging fruit aspects of the plan, so just screening.
I think one of the things that we have to point to is evidence. So we recently did a study where we looked at Medicaid population in Maryland, and we compared individuals who received integrated care with us, meaning they received oral and medical care, whether it be HIV, hepatitis C, and everything else, in addition to buprenorphine, versus people who received siloed care. So they went one place for their overall medical care, another place for their buprenorphine care, which is exactly what we hope why we're here today, I think. So people with integrated care, 79% were still on buprenorphine at 6 months, which is a huge number. And I didn't know this would, I thought we would find that, but our costs were tremendously lower. So we looked at all, Medicaid costs for the year, which included, hospitalizations, ER visits, primary care, and pharmaceuticals, which of course, pharmacy costs were higher in people who had integrated care, but their overall costs were lower. So I think that's an important message.
That's great. We have that population health article in our packet. Judy, you mentioned that getting staff that are trained is an issue. We've talked a bit about training, and one of the issues that came up is that the data waiver requirement tends to be an obstacle. But another is a sense that the physicians that are out there in the community, 90% 4% of them have decided not to get the data waiver. And yet the new physicians, medical students, and other practitioner students and the residents are eager to dive in, and yet we are missing an opportunity here with the training programs because they don't have the faculty that knows how to prescribe, and there are obstacles about licensing and DEA in order to get them to prescribe in their residency programs. But I'm thinking for rural areas like West Virginia, rather than trying to attract someone from outside of West Virginia, if that was a requirement across the board that all trainees, physicians, DOs, nurse practitioners, PAs, got their data waiver, that would alleviate some of your problems.
So I absolutely think that everybody who's getting a degree that allows them to practice medicine in some way or another ought to have the qualifications and the skill set to do that. So it should be a requirement for graduation. I do think there's something totally crazy about spending 8 hours, or if you're an APP spending whatever it is they're required to do, 24, 36, some crazy number of hours of training, when you don't need any of that training to write a prescription for OxyContin. So I think the waiver problem is a big obstacle in itself. I think as people graduate from nurse practitioner programs and medical school who know how to do this and join practices, that will kind of seep through to, I think, more established practitioners. And even more established practitioners might be willing to do it if they didn't have to go through the hullabaloo, which, you say 8 hours, but it's annoying, and then, you have to be willing to be visited by the DEA. I mean, there's just a whole lot of garbage around the waiver system, and I don't see the necessity for it. I see the incredible need for practitioners to be able to do this, and I see the entire waiver concept as being a series of obstacles that thwart that. So from my perspective, I think we should just get the feds to do away with that. Good luck, but that's what I think we ought to do.
I would just add that most people learn, most physicians learn during their residency program really how to do it. So that's during medical school would be great, but if they can actually see patients and write those scripts, and again, the obstacles are, you need three things to be able to prescribe. You need complete the data waiver, your full license, not a training license, and your own DEA, not the programs.
The reason I say during training, first of all, it's just not that hard. Second of all, by the time people get to more specialized training, they already have like stigma and biases and things that they've sort of inculcated as part of the environment they're in. And there isn't, I will restrict this now to physicians, because that's what I am, it's what I understand best. I don't see there's a reason why orthopedic surgeons shouldn't understand the basic principles of pain, medication, prescription, and the dangers thereof. I actually don't see why oral surgeons don't understand this when they give you 30 Percocet for something that might take 1 or 2 routinely. I think you have to get them early before they're hardened by the other influences, social and otherwise, in their chosen sort of field. So I think you need them when they're impressionable. And then, throughout, you can do this through all of the requirements for medical education, right? There's M.H.S. and AAMC, and there's all these other organizations that control what you do in medical schools. There's accreditation of medical schools, and the same thing for training programs. Probably everybody writes a prescription for some kind of painkiller sooner or later, right? So there's just no reason why that just isn't part and parcel of becoming an endocrinologist or becoming a cardiologist or becoming a neurosurgeon. So I think we should start early, quite frankly.
Thanks so much, Judith. So we've been hearing over the past couple of days about a lot of policies that are barriers to this integration buprenorphine waiver is a great example of that. We've also heard about the prior authorization for buprenorphine, the same-day billing, the kind of segregation of mental health records and kind of EHR systems. I wondered, first, can you guys think of other policies that kind of haven't come up over the past couple of days that are barriers? And then second, are there states that have managed to overcome a policy barrier, whether that policy barrier be enacted at the federal or state level?
I'll just mention one thing very quickly that we've encountered, and that is that pharmacists pick and choose what they want to do. And if they don't want to carry Suboxone, they don't have to. And then you might have to go to a community 20 or 30 miles away to get your Suboxone filled. It's the same thing with naloxone, too, right? There's all of these Good Samaritan laws. There's all of this stuff about making naloxone so available. But if you don't want to order naloxone for your pharmacy, you just don't have to. At least in West Virginia, you don't have to. So, I mean, I think these are obstacles, too. You know, these are medications that are life-saving, right? We know that about Suboxone and methadone and naloxone too. They're life-saving, and so they really should be available at any licensed pharmacy. It's amazing to me that you can have the stigma and bias against carrying these drugs so that you don't have them, but I'll bet these pharmacies all have painkillers.
Mm-hmm. So I just wanted to add the minor comment, adding to the prior conversation, is I think part of the required curriculum should be for pharmacists, clinical pharmacists, around addiction and treatment, because that's not necessarily consistent, and I think adds to the stigma when patients go to retail pharmacies and go to get their medication, or they can't get it because of the prior auth that hopefully we can fix. Those kinds of issues, I think, lead to further disengagement of this population.
I'm just going to add a comment about Medicare. So obviously, you know, historically Medicare has not covered methadone treatment, which has been a huge obstacle. Medicare D plans, in terms of covering buprenorphine, at times have extreme co-pays for patients that make it difficult to afford as well. And there should be some way to limit the co-pay that patients are told they need to pay for Medicare D. And then the other thing I was just going to mention briefly, which is also methadone related, is that, and it ties into housing. We recently became aware of some housing that asks people to verify their methadone dose and tells them they can't be on more than 80 milligrams of methadone. So issues like that are huge obstacles.
I'll just jump in with a few additions, which is, I don't know how broad this is, but in Oregon, parole officers can decline somebody's ability to stay on medication for their opioid use disorder. They often have to get permission. That's something that we're overturning, but may have real importance for other states as well. I did mention the SNF issue because it's such a sticking point for us, but I think the ability for opioid treatment programs to be able to deliver or to be mandated to deliver to places if a patient can't come to them. Another thing that I think isn't so much legislative, but in terms of kind of guidelines that I think can be really useful. Several years back, the CDC came out and described that if people have aberrant urine drug screens with benzodiazepines, that it's still appropriate to treat their opioid use disorder. Guidelines like that make a big difference. And you know, I just came from a patient care conference with somebody who has a disseminated candidal infection, including endocarditis, and our surgeons, it's a battle to get them to do valve surgery. So I think thinking about kind of other powerful stakeholders that need to be engaged, and thinking about how do we get the cardiac surgeons on board, how do we get guidelines that we can point to and say this really should be standard of care.
That's great. Just a follow-up question, can you guys think of states that have overcome particular policy barriers? We'd love to kind of identify, you know, here's a barrier that's been cited, and here's a state that actually is doing it right and has figured out a way to handle that.
I think Massachusetts has done a lot around reducing barriers to medication in hospitals. I'd have to double check, but I can get that to you. Similarly, I think I know in Baltimore you guys are doing great work with SNFs. That's really important. Oregon did just overturn this law, or at least it's in process around the parole officers. I can think of other examples and send them.
Thanks so much.
Hi, thank you guys for being here. So as you know, this committee is charged with trying to find best ways to integrate infectious disease treatments and opiate use disorder treatments in the community, prevention from developing infections as well as treatment. And what's good to see is there's a representative here of Medicaid expansion states and non-Medicaid expansion states, and also programs that we've heard that also are more detailed about barriers that they've been experiencing, as well as effective interventions. So thinking about this, you had, say, let's start with HIV. So all of us know, that effective assessment, screening, and then linkage directly to treatment for opiate use disorder can be helpful in preventing HIV infection, as well as among those who have HIV, let's say, effective in treating HIV. And we have a task in this country to end AIDS and end HIV. What do you think would be the most effective strategy, if you could wish for anything, to achieve prevention of new infections in people who are using drugs, and in this task we're talking about opiate use disorder, as well as effectively treating those who, say, cure hepatitis C, get people who have HIV virally suppressed? What would be your magic recommended treatment? So I don't want to put words in your mouth, but other programs who have come before us have said that funding has been a major obstacle, and that Medicaid and Ryan White Care Services have helped them facilitate or be able to offer some of these services. So just wondering what your thoughts were.
I'll share some random thoughts. Over the years, I've always been open to novel things. For instance, we just participated in a PCORI study that was multi-city. It was in the Bronx as well, where we treated recent injection drug users with hepatitis C. And as we see our patients even come to us for overall primary care, it's not unusual for us to see in a note, patients still using cocaine will not treat hepatitis C. So those kind of comments just can't be acceptable anymore. And we, no surprise that everybody here knows that, patients who are still actively using injection drug can take their hepatitis C medications successfully. Obviously, we hope they don't get reinfected. But if we treat enough, that the likelihood of reinfection obviously will go away. So I think we have to open up our, and say that we need to treat people and know that even if they're actively using, we can impact. We still treat their hepatitis C, certainly. So it can't be acceptable for people to be denied treatment on the basis of their drug use.
So I think that the way I would answer that, Sandy, is I would say that what we really need is a huge expansion of syringe services programs that have direct, ideally on-site links to medical care and to addiction treatment, so that the goodwill and the bond of trust that you develop over the course of serving those clients translates into their willingness to be screened and treated, and then at some point, if they're ready for it, also be treated for addiction itself. So we're one of those PCORI sites too, and we've cured 60 out of 62 people. So I think, the concept that we should discriminate on that basis is, absolutely incorrect. Now, there are 8 sites countrywide, and we haven't done the total analysis. So, and I can't speak for the entire organization, but we recruited for this study right out of our syringe services program and the local methadone program. And people cycle in and out of methadone too. So you had to have been injected within 90 days, so that even people who had entered methadone or a buprenorphine program were very recently enrolled as clients of those programs. But I think we've got to make it easy, right? You can't, I know from 30-some years of doing research, as soon as you say to somebody that you have to cross the street to get a chest x-ray or get your blood drawn or whatever, as soon as you have to leave one building to go to the next, you lose 50% of them. Don't make it across the street or to the building next door. It has to be physically co-located, and so I mean, that to me is where the emphasis is: more syringe services programs and more direct medical and addiction care on site.
And I guess I'll just add to that. I agree this issue of meeting patients where they're willing to go and having the wraparound services that I think we've seen supported by Ryan White in the HIV care setting is really what we need to see for patients with opioid use disorder. So not only are they able to get the harm reduction services and the treatment services that they need, whether it be for opioid use disorder or HIV or Hep C, but also get connected to transportation services and food and housing. I think we've seen that work.
Can I jump in with one other thought there, which is somewhat related, but also just a general comment, which is I think we think about prevention, we think about treatment. We don't think so much about recovery-oriented systems of care that support people in recovery. And I think there's just a tremendous, and the peer community has a lot to say about this, at least in our area, and I think it's such an important piece of the continuum of care. I think it could be very powerful to really make a statement about investing in that space also.
Can you point to some evidence that we can use? I fully agree with you, but what sort of evidence would lead to that sort of, and what specific recommendation would you think around that?
Yeah, I actually don't know the evidence in this space. I more have just sort of experience with it, but I can look and see if I can find anything for you.
So what I'm hearing is all of these services are incredibly helpful, but without PCORI funding or without specific other funding, sustainability, ability to do these wraparound services, what would you say about what if there was state mandated funding like we did for Ryan White, where you had to provide opiate use disorder, other substance use disorder screening, and with that other evidence-based treatments like access to medication treatment for opiate use disorder, housing assistance, case management, which needle syringe exchange programs.
Obviously, we're going to agree, and perhaps it should be that if there is such a thing as if someone's a federally qualified health center, they are mandated to provide integrated care.
So what about...
It's a money talks thing.
Do you see any pitfalls to, because sometimes even really well-intended recommendations can have some unforeseen consequences. And how would that impact, would that have any impact on, let's go back to a methadone clinic, you're doing methadone care. Do they just not write for that grant if they want to just keep passing out methadone, or would you think that they shouldn't be allowed to pass out methadone if they're not willing to test for HIV and Hep C and treat it on site? Or I'm sorry, I'm being a little bit, I think we're all agreeing like in the 98%. I'm looking for the what are we going to think about Monday and forget to ask you guys while you're still here.
It seems to me part of this question is how we're defining integration and what that means. And so if integration is co-located, or is it a patient navigator that can get a patient from a methadone clinic to a place where they're going to do appropriate HIV-related care? And I think those systems could be certainly improved if there was systems through, for example, the electronic medical record that were shared and allowed smooth communication. Mm-hmm. So I think depending on what the resources are and the setting, how things are integrated are going to vary, but certainly there should be policies that promote shared communication about patients' health.
What if the hospital was your audience and you were trying, is there a quality measure? Is there most of us hate those kind of things, but is there something, if you have an ED background, you know that, EDs, they have adhered to all of the do this, do that kind of things, and their care changes rapidly when there's a standard of care set for them. So is there something that we're missing that we should put out there that would affect one of these venues that where these kinds of patients are frequently coming?
I'll just add a quick reactionary thought to that question. I think we talk about door-to-balloon time, for example. I'm not an ED doc. I'm just doing some work in EDs. But we talk about door-to-balloon time, for example, right? And so you don't leave patients who are having acute angina without an acute MI without intervention. And I think we need to change how we're thinking about opioid use disorder. So if you have a patient diagnosed with opioid use disorder and you're not providing evidence-based treatment, that should not be acceptable.
I just want to mention one other obstacle I thought of, which is CFR 42, which silos the way we provide addiction treatment. I think that has to be modernized, and in fact probably perpetuates stigma and prevents good care. So I just thought of that as you were saying.
Maybe we can drill down on how that might be modernized. Does anybody have any good suggestions?
Yeah, I think when it was obviously written for protection, but at the same time, I think a lot of thought was given into how people have HIV diagnoses. So I think HIPAA has come about since CFR 42, and I think there's a push, although it's raised a lot of dissension, that why don't we just modernize it since we have HIPAA now to include addiction treatment, including things like methadone, because it's very harmful to not know, for instance, I'm taking care of a patient with HIV that I don't know that they're on methadone.
Dr. Chapman, and just be mindful we just have a few minutes left.
Do we have anyone that has been to France or Portugal to study what they did 20 years ago? I think we had a similar situation about 25 years ago when Viagra came out. My office, for the first time, had more men than women, and we were then able to treat their blood pressure, diabetes, and make contingency arrangements with them that they could get another prescription if they followed up with that. So it seems that we've instituted every policy imaginable, from patient caps to generic buprenorphine that costs no less than the brand names, so that we can perpetuate this the prison industrial complex with folks making jumpsuits, fighting back against losing their business. So, I mean, is capitalism killing our ability to get success?
Well, I think that's a great question. One thing underlying all this, and you know, where we are in Connecticut, we still operate under Medicaid is nearly completely fee-for-service. And that's a huge barrier for us as we try to move forward, because at our FQHC, you know, we're practically incentivized to have me manage the opioid use disorder, have the patient come back to see the HIV specialist, come back to see the behavioral health specialist, and maybe all those professionals need to be involved, but our system right now, as a fee-for-service dominant system, prioritizes or incentivizes us to separate those visits and not necessarily communicate. Whereas as alternative payment models come down the pike, I would hope that we could anticipate that and think about what metrics we want to be measured on as we think about this population, because then we'll be incentivized to actually meet them where they are and take care of as many of their problems as they can in that one moment, in that one visit.
Great.
Can I jump in with a comment that's actually getting back to a question recently about the hospital piece, which is I think that there's a huge opportunity, you know, in terms of sort of thinking about these serious infections. We just looked at some of our data, and in terms of predictors of initiating medication in the hospital, homelessness and a partner with substance use were really strong predictors of medication initiation, which I think really tells a story that people aren't accessing treatment in other places. And so I think it further speaks to the fact that hospitals really should be mandated in some way to provide at least a portal to treatment. And we saw with the 30-day readmission measures that, you know, everybody was running around like crazy which I think is kind of not a good quality measure, but huge attention. So there's ways to get hospitals to pay attention to these things. And I think, again, just really important.
Ellen?
a quick question. One area that we have not addressed is this new wave of non-HIV, non-Hep C, but endocarditis, bone and joint infections, all these very morbid and costly complications of substance use disorder. And I'm curious, I've talked to Carlos, and I know from the UAB experience, we do not have a great way to care for them in the community. We have this integrated intervention in the hospital setting, but how are those folks cared for who don't have HIV, so don't have Ryan White Care Act funds? We're a non-Medicaid expansion state, but how do you care for them, and how do you provide resources to do that type of care?
Is that a question for me?
Sure.
Everyone else is shrugging, so go for it.
We are really struggling also, though I think doing some things that are effective. One of the things is it used to be that people were basically told they had to complete a course of antibiotics in the hospital, or that there was nowhere else for them to go. And we've started really modifying that such that we're allowing people to do outpatient infusions if they really want to, and we can put some protective factors around them. We continue to try to work with skilled nursing facilities, and we really developed a format that's kind of a structured meeting with our infectious disease, addiction, and primary teams to prioritize patient preferences, but there's got to be better models and better ways.
So, yeah.
With state funds, we've built I think it's a 27, 28 bed facility nearby where when people are no longer acute enough to be in the hospital, they can be transferred and they can, come in for the day, get their infusions. They can either stay or not stay overnight. Because we have the same sniff problem that was described for previously, that you can't get skilled nursing facilities to accept these patients, or at least not in West Virginia. It's weird because it's very state dependent. We had no problem doing this in Ohio. As soon as someone was ready to leave the hospital, day 9, day 10, they're stable, they don't need cardiac surgery, out they went to a skilled nursing facility. But neighboring Kentucky and West Virginia can't do that. I haven't been able to fathom why this is a problem. I've seen people overdose in the ICU at the University Hospital in Cincinnati. There's nothing magic about where you are. If you're determined to use, you're determined to use. So I don't quite get that. But, it was expensive to build this facility, and it was a big investment. I don't know that that's at all a model for lots of other places, and it's relatively new, so we don't have a lot of follow-up data yet, but I think you do have to think out of the box for how are you going to manage patients long-term instead of having them leave AMA and never finish a course of antibiotics.
The transitions from healthcare settings to the community is a critical one for many of these diseases, and also I would point out for correctional facilities as well. One theme that's really come up is that we have seen this type of problem before, a complicated problem with multiple deaths of young people, and the biggest intervention that we did was the Ryan White Care Act. And so one thing we've been discussing is thinking about how to take the lessons we learned from having the CARE Act and translating it into interventions that would stimulate the kind of interventions that can integrate care for infectious disease and addiction and other things as well. Maybe anybody have comments on that? And yeah.
I fully endorse Ryan White Care Act that would help serve patients affected by opioid use disorder. I think that's a critical part of the solution.
I would add.
So just briefly, I would support that as well. I think at our FQHC, we have, thanks to Ryan White, 2 care coordinators for about 200 patients with HIV, and then we have about 4 other care coordinators for the remaining like 1,600 patients, 16,000 patients that we see at the clinic. So patients with opioid use disorder without HIV are in this no person's land, whereas once they may acquire HIV, they get these services, which is just sort of the wrong way to have a system like this.
Honora?
I totally agree and support that. The one other thing that I'll just add as a general framing is I think certainly in the West Coast, we see so much methamphetamine use disorder, which is really driving a lot of overdoses, a lot of deaths. So my hope is that at a national level, we can expand our view beyond opioids, because I think it's really it's a crisis.
In the opioid-afflicted areas of the country are seeing a massive shift to methamphetamine use. So I think the real issue is not to focus on the drug class, but to focus on the concept of substance use disorder, because, you know, it doesn't help people in the field. Federal money comes to the states now, and all of this, you know, STR and SOR money is opioids, but opioids are disappearing. So now what do we do with all the people who are injecting methamphetamine? So I think we just need to have a broader, totally agree, I think we need to have a broader picture of this entirely.
I was just going to add a somewhat unrelated point that I think came up earlier, is thinking about novel venues for dispensing medications for opioid use disorder. So we can learn from international settings around pharmacy dispensing for methadone, for example. And I think that's something we should be learning from in our experience as we inform what happens here.
At this point, I would open up to the floor if there's any questions or comments. Please identify yourself. And
hello, so my name is Frank Hood, and I'm with the AIDS Institute, and we focus on ensuring individuals with chronic conditions have access to treatment, mainly focusing on HIV and hepatitis. And I just wanted to reiterate something that's come up multiple times today, which is the need for state and federal investment in these issues. And not only the need for investment, but also the need for investment, particularly around reaching individuals who aren't reached by Medicaid or Ryan White, especially in the non-expansion states. But also investment that isn't siloed. A lot of the funding we see from the federal level comes in like, you know, this is HIV funding, this is hepatitis funding, this is addiction treatment funding. And as we've heard throughout yesterday and all day today, successful models incorporate all of this together in one package, and that becomes a lot easier when funding can also kind of, you have one source instead of picking and choosing. So hopefully we can see some increased investment from state and federal agencies that allow less siloed, I guess, restrictions.
Great. Thank you very much. I think we are... any last comments? This has been an exciting discussion. I think I'm taking home Edwin's comment about Viagra and Judy's comment about Madison Avenue, thinking how are we going to make getting rid of stigma sexy? One last comment, Dave.
No, I think I just speak for the other panelists in thanking all of you for your time and your commitment, especially. It's been inspiring to see your examples, and sort of restores some of our faith in the future of in human beings and the future of healthcare. So I know that what you do is exceptional and goes with a lot of obstacles. But thank you for that, and thanks for taking the time out to share with us.
And finally, I would just add that if other thoughts or ideas come up in the next few weeks, please send them in to Andrew, and he can send an email to all of you. Thanks again. Bye.
Thank you so much.